The purpose of the spanning plate is a concept that developed because external fixation had some problems. Patients and surgeons had difficulty with external fixation. There was a high complication rate, everything ranging from tendon injury to nerve injury to complex regional pain syndrome, malunion, non-union, and the list goes on and on. So spanning plate tries to solve those problems. The easiest application for the spanning plate would be anything you would use an external fixator for. These would be the highly comminuted intra-articular fractures that are very difficult to put together and repair with fragment-specific plating. Perhaps a grossly contaminated wound, perhaps even a wound that has some soft tissue issues with coverage. These would all be indications for spanning plating. Then the indications may actually expand to involve more fracture dislocations with dorsal rim and anterior rim fractures, failed lunate facet fractures, also the osteoporotic fractures, the very soft bone that fractures very distally and the articular surface is very comminuted. That lends itself very well to this type of technique. And the list really goes on, including non-unions, people that need to weight bear immediately, such as the polytrauma patient or bilateral distal radius fractures, or maybe the elderly that uses walkers or some other assisted ambulation devices. And it's even being used for Kienbock's disease as a treatment. So there are a lot of indications beyond just the original application of replacing external fixator. I would say if you are completely lacking soft tissue, it's been degloved, that's something that you wouldn't want to put internal hardware in. That would be an indication for the external fixator, but that would be so rare that it's almost never happening. Obviously, for more simple fractures, extra-articular fractures, fractures that are easily fixed with either a volar plate or simple fragment-specific fixation. There are some surgeons that may be able to feel comfortable fixing most things with fragment-specific fixation, but we all know that surgeons have different skill levels, and some have a time where they would spend too much time in the OR, too much struggling, compromise the reduction, and the spanning plate offers a very good alternative for those surgeons. So as I said before, the spanning plate attempts to solve some of the problems with external fixation. One of these problems is overdistraction. In order to achieve a reduction and maintain it, a lot of force is needed, a lot of traction is needed pulling across the joint. This sometimes over-distracts the joint. And as a result, there is capsular hypertrophy of the wrist, and there is going to be consequent digital stiffness because the fingers just simply can't go into a fist during the recovery time. This causes problems for hand function. So because the moment arms are much shorter in the spanning plate, the amount of force needed to obtain and maintain a reduction is much less. And so overdistraction is less of a problem. That's the first thing. The second thing is that we have no external hardware. We have no external pins to get infected. So there's no problems with osteomyelitis and pin track infections. As a consequence to that, not only is it just healthier, you're able to keep this spanning plate in longer than you would keeping an external fixator on. And that is advantageous at times. Patients tolerate it much better. They're happier with it. They don't like things sticking out of their skin. It just seems to be a more predictable device. You can weight bear on it much more confidently because the construct is so much stronger than external fixation. Well, it's a very simple technique, but there are some things to keep in mind. So the basic technique is to start with 2 incisions, and there are 2 types of techniques. You can either put the spanning plate over the second metacarpal or the third metacarpal, and it's not an arbitrary decision. If most of the work needs to be focused on the radial side of the wrist, the radial column, such as a very comminuted radial styloid or a very steeply decrease in radial inclination, then probably putting the spanning plate over the second metacarpal is recommended. If most of the work is on the intermediate column, displaced lunate facet, comminuted medial intermediate column, or they're both columns involved, then I would recommend putting it over the third metacarpal. I think you have the most flexibility. If you have a radial carpal dislocation where you have a rim fracture, either dorsally or volally, I think also the third metacarpal is the best option. It gives you a lot of flexibility. And if you have to weight bear aggressively post-operatively, I think the third metacarpal is the best because it is proven to be a little bit more stable than the second metacarpal, particularly in rotation. So the technique for both the second and the third metacarpal placement is about the same. I'll start with the second. So an incision is made over the second metacarpal and the dissection is taken down to bone. It is particularly important in this dissection to look for the superficial branches of the radial nerve. They are at risk during this incision. The plate is actually engineered so it passes very easily through this incision subcutaneously until it reaches the radius, where then it tunnels underneath the second dorsal compartment. And it's advanced until the bend reaches the carpus. At that point, the hand is then extended to meet the plate. Once in this position, the screws are then placed distally. There's an oblong hole in the plate that allows for fine adjustments to be made based on your radiographic assessment. And then when you like the position of the plate and it's centered well over the radius, then the rest of the screws are placed. And it's very important to place the screws distally in the metacarpal first before the radius for many reasons. The first being that there's not a lot of real estate to put screws in the metacarpal. And if for some reason it's off a little bit and it's not as precise and centered as you liked, that could predispose the metacarpal to have a fracture iatrogenically, which would obviously be not optimal. Also, now that the plate is fixed to the metacarpal, you have the advantage of pushing the plate proximal to distal to help with your reduction. It's not just a longitudinal traction with the hand, but it can also be a pushing force as well if you need it. Then a second incision is made after palpating where the plate sits on the radius here. Its dissection taken down, and then the screws are then placed. Again, there's an oblong hole for fine adjustments once you've obtained the optimal distraction that you need to reduce the fracture using ligament ataxis. And then the final screws are placed. At this point, after you're happy with your reduction, as much as ligament ataxis will give you, you can make some accessory incisions around the fracture and take a small elevator or something to that effect to reduce the fracture a little bit better if you need to. And then you can put pins in or fragment-specific plates or screws or whatever minimally invasive internal fixation you would like to help refine the reduction and fixation. Similarly, there is a third metacarpal plate, and the technique is largely the same with an incision over the third metacarpal this time. And again, it's passed distal to proximal with the wrist in a flexed position, but this time the tip of the plate is on the ulnar side of Lister's tubercle as it searches for the space underneath the fourth dorsal compartment. It's advanced, and if you can see this, the plate has a bend in the sagittal plane that when it finally hits the right position, it fits quite nicely in that area, and the surgeon will feel a little clunk telling them that they're in the right place. And it's a very obvious, very satisfying feeling when you reach that position. Again, the wrist is then brought up back into extension to meet the plate. The screws are placed distally. The same reduction maneuver is performed. An incision is done proximally, and the plate is secured proximally as well. And the same accessory fixation could be used in addition to bone graft or anything else you may use. Again, it's all minimally invasive, sparing the blood supply to the fragments and very easy on the patient. So there's always a question about how a surgeon can get into trouble with any technique. And there are really 4 things to be aware of when doing the spanning plate. The first, we've already talked about. When you make this incision over the second metacarpal, the superficial radial nerve branches are at risk, and so they need to be carefully dissected out or a neuroma can happen. Not so much of an issue over the third, but over the second it's at risk. Also, when you're making your incision proximally with the second metacarpal plate that lies like so, you are also in the territory of the superficial radial nerve, which is around this area as well. It's not a blind dissection. It's not a aggressive dissection. It's something that has to be teased apart carefully. That's the first thing. The second thing is whether you're using the second metacarpal or the third metacarpal with either plate, the placement of the screws must be centrally located on the bone. They cannot be cockeyed, eccentric, or whatever you want to call it, because that can cause a stress riser, that can cause a fracture of insufficiency. There's going to be a lot of force on this plate, and you want it to be equally distributed through the bone. Now, the third problem is over-distraction. And we mentioned this before, but with external fixation, there tends to be, I can't do it with this model, but when you pull a lot of force on this, the joint separates quite a bit. You never want more than 5 millimeters on the fluoroscopic clear space between the radius and the carpus. Never more than 5. If it's more than 5, you're over-distracting, and you're going to have problems with capsular hypertrophy, causing wrist stiffness post-operatively, and the patient will never be able to make a fist when this plate is on and causing digital stiffness that could be permanent. So that's the other thing you don't want to do is over-distract. And if you feel the need to over-distract, it's probably best just to put some distraction, make an accessory incision, take an elevator, and push up the fragments you need to push up rather than relying entirely on ligament ataxis to do it when obviously it's not doing it. The last thing, and that's kind of a neat thing about this plate, is that traditionally straight plates going from the third metacarpal down to the radius, there is no natural plane between the fourth dorsal compartment and the metacarpal. It doesn't really line up. You can kind of see how it takes a zigzag around Lister's tubercle. Straight plates have to just blow right through Lister's tubercle. In the process, there's been a lot of problems with impingement of the extensor pollicis longus tendon. So the tendon gets trapped underneath the plate, and the thumb cannot move, and that tends to be a permanent problem, often causing rupture and the need for a tendon transfer later. So, as a result, surgeons have recommended making a small incision when using a straight plate just to radialize EPL out of its position away from the plate so there's no problem there. It's not a big modification, but the plate that is designed here gets around that problem altogether. So if EPL is running right through here as it takes off toward the thumb, this plate runs alongside EPL, and as it hits the fourth dorsal compartment, it swivels around until it hits the right position so that EPL is not impeded at all. Now, it may be prudent, particularly when the anatomy may be altered with the trauma, to make an incision and be sure EPL is still safe. But the plate is designed to move around EPL in most anatomic cases. So how does this plate help us with our reduction? Once the plate is placed, then traction is applied to the joint, and most of the reduction occurs through ligamentaxis, much like external fixation. There are some fragments that don't come together perfectly. We know this by our experience with external fixation, and that's okay. In that case, we can make small incisions using an elevator to manipulate the articular surface or whatever fragments are still not quite right. And then we can use percutaneous pins if we need to, a fragment-specific plate like a radial plate or a buttressing plate of some kind. These can even be used with volar plating, where the bone is very soft and we worry about the soft bone melting around the screws. So as a neutralization device, it can be quite helpful. So there are many augmentation you can do with the spanning plate. The spanning plate does not have to be used exclusively. Now, there are certain types of fractures that are even challenging for fragment-specific plating, and I can talk about that now. So there may be fragments that are difficult to control in the distal radius. One may be a very displaced radial styloid, highly comminuted, and like I said, when that is the challenge, the second metacarpal plate may be the best option. And when that's in place, you can kind of see how it will buttress that radial styloid. And there are also holes here that you can use to lock in screws to help stabilize either the articular surface or the radial styloid itself. Similarly, if you have a displaced dorsal ulnar fragment, which can be very difficult to control without fragment-specific fixation, the third metacarpal plate fits nicely over this area and buttresses that as well. Again, you have a screw here that aligns very well along the articular surface of the lunate facet, and if you have a dye punch lesion or something of that nature, it can support the fragment quite nicely. If there are volar rim fractures or teardrop fractures that can cause some subluxation of the carpus anteriorly, the third metacarpal plate is quite nice because that screw hole then can grab, this volar fragment and either pull it in with a non-locking screw or stabilize it with a locking screw depending on your needs that you want, without having to make an anterior incision and put on a separate plate. Generally not. It's really not necessary. If you feel the need to use it for soft tissue comfort in the immediate postoperative phase, you can do that. But generally, I just wrap it with a soft bandage and allow the patient to weight bear right away. It's that strong a construct. Generally, when it's for most fractures, I would say it's removed in 4 months. These are the highly comminuted fractures that take a little while to heal. Now, if you have a much simpler fracture and you think it can be removed in 2 months, you can probably get away with that. If it's a soft tissue primary problem, it's a fracture dislocation with maybe a rim fracture, that generally is removed in about 4 weeks. But for most fractures, I think 4 months is probably the standard. But although 4 months is the general time, the range of motion is excellent after the patient undergoes physical therapy. The amount of mobilization doesn't seem to affect the overall outcome. Well, the traditional spanning plates are just straight plates taken out of a set for other fractures for the forearm, and one of them is a 3-5 DCP plate. It's very bulky. And it's very difficult to pass, and if we're talking about tendon entrapment, that's the one that seems to cause the problems, at least in my mind. So this Medartis plate is extremely low profile. It's tapered on either end for easy passing. It's the right width as well, so it passes through the tunnels the way it needs to be. So it's appropriately sized, it's appropriately contoured. In addition, there are some plates that have a pre-bend in them, and that bend is to allow some extension, with the idea that patients will be more functional if they have a little bit of wrist extension than had they've had a completely straight wrist. And that seems to be true. You can certainly have better power grip with that. Also, there's a theoretical advantage of when the plate is removed, they're going to have an easier time getting their extension back, which sometimes can be a problem. So the Medartis plate certainly has that as well. But the really unique thing about the Medartis plate is when you want to use that third metacarpal, it curves around anatomically, it follows the anatomic structure of the wrist, and it avoids problems of EPL impingement, minimizes that risk significantly, and it's much easier passing and takes the guesswork out of the operative procedure.